Ms. Mariam Jaafar.
Mr. Speaker, I declare that I'm a managing director and partner of a management consulting firm that does work in the healthcare space. The rising cost of healthcare is a threat to our government budgets and to our economy. It is a growing financial and emotional burden on our families. It has already been cited as the reason why we have to do the unpopular and raise GST, despite the political costs. It is, in a word, unsustainable for Singapore. It's unsustainable for Singaporeans like my Woodlands resident, Mr. Z, whose wife suffers from diabetes. Mr. Z comes to my MPS, he has problems. How to cover the cash co-pay for her next hospital visits, how to pay for the bags and other consumables that are not covered by MediSave, how he is going to push her in her wheelchair to the NKF center for her dialysis treatments. These days, often in the rain, when the growing arthritis in his bones sends waves of pain up his legs and back. It's unsustainable for my resident, Ms. N, who has worked hard to build her career. But one illness to her aunt, who lives here on a long-term visit pass, has wiped out a huge chunk of Ms. Ng's savings and continues to take a chunk out of her take-home pay every month. It's why my resident, Mr. T, refuses to go for checkups, let alone screening. If they find something, I don't have the money for treatment. So better don't know, as Min Ong says, it was exactly what Mr. T said. So we have a healthcare system that is admired. We are living longer. And at this point, I want to react to the comment by the member, Ms. Herting-Roo, who stated that we are living longer but not healthier, and that MOH tends to look at life expectancy rather than more healthy indicators. And actually for this speech, I did look at that data, and she may want to know that for the specific data point on health-adjusted life expectancy, or HALE, MOH does actually track that, and it's been increasing year on year. And based on the global finding, our HALE at 73.9% in 2019 is actually the highest in the world. So I just wanted to give some the credit to MOH there. Our hospitals do a great job at treating the sick, but could we have done more to avoid people getting sick in the first place? Could we have done more in taking decisive, holistic action on preventive care, on a national focus on population health that permeates everything we do in our daily lives, from the food we eat, the exercise we do or don't do, the amount of screen time we allow our kids, that might have helped us prevent the rise of chronic diseases like diabetes, hypertension, and lipid disorders. And so for these reasons, Mr. Speaker, I say that Healthier SG is not just a good idea. It's necessary and overdue. Too much has been spent on acute care, too little on prevention. More people are getting sick, living with chronic illness. They're getting sick earlier in their lives and will require medical care for a long time. Add to that an aging population and rising costs, and we have no choice but to make this work. HPB has worked hard to promote healthy living, but HPB can't do this alone. It's time we recognize and ensure that incentives, norms, practices, data analytics, policies must be aligned to the behaviors we want to drive across the system. Not only the behaviors of doctors, nurses, hospital administrators, everyone in the healthcare system, but also of the community, or patients, and currently healthy citizens to take charge of their own health. There are many things to like in the Healthier SG white paper: mobilizing GPs, removing copay, free vaccination, cheaper drugs at the GP, social prescriptions, leveraging community assets and solutions. Colleagues have talked about it today. I would like to focus on 3 enablers to making Healthier SG happen: healthcare financing, IT, and manpower, as identified in the white paper. But before I go into the enablers, I'd like to frame them in the context of what it is we're trying to achieve. How do we frame the objectives? The ultimate objectives must be better health outcomes at lower costs. And indeed, this is the objective of healthcare reforms around the world, towards a model commonly known as value-based healthcare. But when we look at the KPIs for Healthier SG, many of the KPIs, especially in the near term, are process indicators, things like enrollment rates, screening rates, vaccination rates, and yes, health plan completion rates, while health outcomes like disease prevalence and control, mortality, readmission rates, frailty start to figure only later. Now, Mr. Speaker, there's a whole body of knowledge that has emerged in the field of value-based healthcare around health outcomes measurement, such as the U.S. Center for Medicare and Medicare Services, or CMS, and its Meaningful Measures Initiative, as well as the International Consortium for Health Outcomes Measurement, or ICOM, and its range of condition-specific standard sets of outcomes for different age groups and different demographics, including clinical and patient-reported outcomes. Patient-reported outcomes includes measures of quality of life. For example, do they feel pain, their ability to perform activities in daily living, sense of control, their moods, loneliness. So why all these efforts? Quite simply, because without measurement and transparency of outcomes, we won't know whether what we're doing and paying for is having an impact and how much. Doctors and clusters won't have the data they need to make better decisions and drive innovation, teamwork, and best practice sharing. We need outcomes that are measurable, effective, and standardized across clusters. It takes time to identify, find ways to measure, and to show the value to everyone in the care delivery chain, so it's not seen simply as an administrative overhead. This is not something we can leave to the clusters. I repeat, not something we can leave to the clusters. MOH leadership is needed. So I call on MOH to consider including, as another pillar of Healthier SG, a drive to accelerate the identification, measurement, and transparency of health outcomes. Now, it's very true that there's a big risk in transformation as fundamental and complex as Healthier SG to expect too much too soon. But the evidence from successful value-based healthcare systems has shown that meaningful health outcomes can, in fact, be achieved sooner, but for defined patient segments, particularly at the intersection between primary care and the secondary and tertiary space, such as at the point of discharge from hospitals. For example, a general nutrition education takes a long time to pay back, but Oak Street Health, a relatively young and innovative US primary care provider, found that making sure elderly patients with diabetes are eating properly when they are first discharged from hospitals has very rapid payback in terms of lower readmission rates. Another example, in Sweden, the Stockholm County Council launched a value-based payment program for hip and knee replacement in 2009, led to a rapid shift of care from acute care hospitals to cheaper specialty clinics. And in the first 2 years, complications decreased by 18%, reoperations by 23%, revisions by 19%, cost per patient declined 14% in terms of resources used by providers, and 20% in terms of money paid out by the council. Finally, the LUMOS program, an initiative to integrate healthcare data in Sydney, Australia, developed a model that shows the high value impact that can be obtained through early detection in primary care specifically. When a patient is diagnosed with diabetes early in primary care and has regular GP visits forthwith, their diabetes journey is much more likely to be managed over time in the community setting. In contrast, when the first diagnosis is done later and in a hospital setting, and he does not engage much with primary care, this could result in poorer management of diabetes and increased readmissions. But here's the good news. The LUMOS data also suggests a GP visit within 1 week of discharge of an unplanned readmission can substantially reduce the risk of an unplanned hospitalization in the 5 to 12 weeks following discharge. That is data that we can actually act upon and do something about. So the common thread in each of these examples is think big, but start small. Focus on a specific population group and patient segment, for example, people over 60 with diabetes, and identify a subset of outcomes for that patient segment and set the system to work to track and improve those outcomes and make this visible. And I stress to focus first on measuring and tracking and doing something with it. I'm a little bit more ambivalent about the suggestion by the member, Mr. Gerald Yam, to put a target on every KPI. Especially with some of these KPIs, it's, as Member Denise Farr said, it's very easy to achieve them. It can set some really perverse incentives. What's really important is to identify the right KPIs, measure them, and actually use them to make our system better. So I urge MOH to make a real push to measure health outcomes from the beginning. And with this lens of focusing on outcomes, I turn now to what it's going to take to make Healthier SG work. First, healthcare financing, an area that will undergo significant reforms in Healthier SG with a move towards capitation funding. Now, the drawbacks of our current model of fee-for-service are clear. motivates doctors to take on more and more patients, even if they don't have time, to order that extra MRI, even if it's not really necessary, to prescribe the most expensive drug instead of a generic that does the job. It feeds off a very human trait, love. Love that makes us willing to try anything, spend anything, if we believe it might keep our loved ones alive. And trust me, I know how that feels. But Mr. Speaker, more expensive care is not necessarily better care. More treatment is not better care. This is why healthcare systems around the world are implementing payment reforms. There are different forms, pay for performance, bundled payments, capitation, and they can be used in combination, but the fundamental logic is the same. Pay for quality and value rather than volume. Capitation, in particular, gives healthcare providers a powerful incentive to manage total systems costs. Most capitation systems are geared to encourage providers to focus on prevention and early detection and intervention. One successful example is CMS Medicare Advantage in the US, where Medicare pays private insurers a fixed risk-adjusted payment for the total cost of care for a patient. Then it's up to the insurer and its provider partners to figure out the best way to use that money to provide the care. Insurers such as Humana have built their own or partnered with provider networks to help them create more value-based models. So Oak Street Health, which I mentioned earlier, is one such Humana partner. Oak Street Health clinicians are given the autonomy to do whatever drives best outcomes for the patient, working in multidisciplinary teams of GPs, nurses, specialists, nutritionists. They take input from the patient and caregiver and also consider the patient's social determinants of health, such as food security and social support. This holistic approach often drives new insight and innovation. So if the patient needs a surgery to be healthy, they will make the referral. If he needs food delivered to him to make sure he eats healthy, that's what they do. Or if it takes a house visit to make sure that the home does not have hazards, a stray rug or slippery tiles that could cause him to trip and fall, that's what they do. Or if they think the most meaningful thing is to have someone put their arm around him to be comfortable with his life situation, that's what they do. And they are achieving good outcomes. Another example is Kaiser Permanente, also in the US, where transparency about outcomes and costs encourages the clinical teams to avoid low-value care and right-side care within its integrated network of hospitals and primary care providers. The system of incentives encourages clinicians to work together and share best practices and always driving continuous improvement. These successful models point to a few prerequisites for capitation to be truly value-based. It needs to be organized around defined patient groups and population segments, adjusted for risks, and linked to quality thresholds or improvement in health outcomes. Otherwise, capitation could create incentives for cherry-picking of healthier patients or for limiting access to required care, or what we call rationing behavior. To that end, can the minister clarify the capitation model envisioned under Healthier SG, including how will the payments be risk-adjusted based on patient profiles in the cluster? Will there be bonus payments for achieving better health outcomes? How will health outcomes be shared to encourage, across the delivery chain, to encourage people to work together? And how much autonomy will be given to the clusters and clinical teams to do what they believe is right to deliver better care, informed by care protocols, and outcomes? Can there be participation payments for tracking and reporting health outcomes? And how will adjustments be made at the back end when someone uses healthcare services outside his or her own cluster? Second, healthcare IT. The enhanced National Health Electronic Record System under Healthier SG is much needed. We shouldn't need to tell every new doctor or specialist we see about our medical history or our prescriptions, or to have to repeat expensive tests and x-rays, or to repeat information needed by our medical social worker at every hospital you or your child goes to. Digitizing and automating processes, leveraging mobile apps like My Health Hub and Healthy 365, all these make sense, though implementation is non-trivial, as some colleagues have raised. The Honourable Member Tan Wu Ming has made the point that digital solutions must be easy to use and reliable. I absolutely agree. To change behavior, though, doctors and patients alike must be excited and willing to use these tools. And here's where the lens of outcomes pushes us to go even further, and that is data. clinical data, pharmacy data, health screening data, health app data, cost data, but also data about the individual and how he likes to be engaged. Can we use all that data and analytics to identify risky individuals for whom we can have the right conversations and make the right targeted interventions in order to make meaningful impact? Can we engage patients and physicians not only with apps and technology and tools, but with data that tells them where they stand in comparison to others and advises them with personally relevant information of actions that they can take, including, of course, working with community partners. I think the role of data and analytics can play in driving outcomes for healthier SG is incredibly interesting, and I would suggest doubling down on the capabilities to do this. Last but not least, healthcare manpower. Now, I've spoken a number of times in this parliament on the adequacy of healthcare manpower, including the shortage of nurses and the need for healthcare manpower transformation in preparation for a future that's much more focused on value-based care and prevention. So for Healthier SG to work, we not only need more nurses, we need enough good family doctors, nurses, allied health professionals, pharmacists, care coordinators. They must be comfortable dealing with a wider range of complex conditions, working with data and technology, working in multidisciplinary teams, including specialists, and new ways to engage patients. We need everyone in the healthcare delivery system to be rewired around prevention and putting care in the right place. This will not come naturally. Today, they're not trained in that way. They're not compensated in that way. And let's face it, that intellectual respect, our intellectual respect, is not for prevention. Our intellectual respect is for the surgeon who pulls off a complicated surgery. So we need to respect family doctors a lot more. But if Healthier SG is to succeed, we've got to get this rewiring right. I believe that for most clinicians, the language of health outcomes is an inspiring and powerful one versus administrative tasks. It can underpin the enormous change management effort that will be required. Mr. Speaker, MOH has implemented a series of individual reforms in recent years. Healthier SG is a fundamental and comprehensive transformation that will require institutional commitment to work things out, considerable investment, and new organizational and people capabilities and ways of working. They say health is wealth. To put our healthcare system now on a more sustainable footing and to get a healthier Singapore and Singaporeans. For Mr. Z, for Ms. N, Mr. T, and millions of other Singaporeans like him, we cannot fail. I support the motion.
Order. I propose to take a healthy break now. Suspend the sitting and we'll take the chair at 4:40 p.m. Order, order. (5:40 p.m.) That's why we need a break.